Thank you so much to the organizers for inviting me, and thank you, Sridhar and Saurabh, for being such wonderful hosts. It's my pleasure to be here today in Dubai, talking to all of you about patient safety in perinatal care. I don't have any conflicts of interest to disclose, and I do not intend to discuss any unapproved or investigative use of commercial products or devices. I do want to start my talk, as I do all my talks, by acknowledging my teachers over the years, from my MBBS days to my DM fellowship and so on. I've had the good fortune to work and learn from many, many expert and wise people. And I always like to start my talk by thanking them for the knowledge and wisdom they've imparted me. In 1999, the Institute of Medicine in the US released a report called To Err is Human. And they pointed out that in the US healthcare system, there's a staggering number of deaths every year from medical errors. And in that report, they said every year, 44,000 to 98,000 Americans die each year in the country. These are patients of all age groups. And subsequently, these numbers were proven to be an underestimate. The real number of deaths from medical errors is actually much, much higher, especially if you consider diagnostic errors, which we'll be talking about. They pointed out the number of deaths from medical error is much greater than the number of deaths from motor vehicle accidents, breast cancer, and HIV. We pay so much attention to these other causes of death, but not to patient safety, and they said we need to change that. This report kick-started the patient safety movement in the US. I got involved with this because I was working with the Vermont Oxford Network. And for 13 years, I taught a course on patient safety, and I was heavily steeped in this. And today, in my work as a deputy editor for the Joint Commission Journal, we handle a lot of manuscripts related to patient safety and projects related to patient safety. So I'll be sharing some of what I know as applied to neonatal and perinatal care in this talk. Actually, in neonatology, there was widespread recognition of the problem of medical errors way before the Institute of Medicine report was published. In 1968, B.F. Andrews published this diagram it was simply called the hand. And this was meant to remind us about differential diagnosis. When you have a patient, you definitely, in the differential diagnosis, you consider cardiorespiratory causes, metabolic causes, hematologic causes. But B.F. Andrews reminded us, always consider iatrogenic causes of a problem. And that is the sixth finger, and it is tied off, symbolizing that errors have to be prevented and iatrogenic harm has to be prevented. So neonatology actually had started talking about errors in 1968. But the Institute of Medicine report actually kickstarted safety movement, and we adopted that in neonatology in the US as well. So I want to cut to the chase, and I tell you, in your neonatal unit or pediatric intensive care unit or your children's hospital or department, if you want to institute a patient safety program, there have to be 5 elements which are listed on this slide. Use reliable methods to identify safety events. Perform a systems analysis of each event. I'll talk a little bit about that. Ensure that you have good mechanisms of disclosure, apology, and care of the second victim. Implement safety solutions proactively as well as reactively. And finally, improve culture, teamwork, and leadership, because those are the secret to high quality and safety in any unit. Without that, everything else will be flawed. So let's look at the first element in this, which is identifying patient safety. Think of how you find out about safety events in your unit. You might have a reporting system, you might hear about it from nurses or colleagues, you might hear about it from lawsuits, patient complaints. But there are 2 papers listed at the bottom here by Thomas and Peterson and Robert Ersprung and colleagues, which describe the various methods of identifying safety events. First, you can have clinical surveillance, where somebody goes around, checks on every patient every day, and detects whether or not things were done right or wrong. The most common method used in most units now is reporting. All hospitals in the US have a reporting system, and people report events into the system anonymously or in an identified manner, saying that this patient got a medication overdose, or that patient's dose was delayed, or somebody performed an operation on the wrong site, and so on. Robert Ersprung and colleagues, and I was part of that work, performed random safety audits where you go around at random and check on patients for specific. Is the pulse oximeter set at the right alarm? Was the last dose of caffeine given at the right dose? So you can have randomly generated questions, which will reduce the burden of data collection and still give you usable data. Of course, in mortality and morbidity meetings and in autopsy reviews, sometimes you find out things that were not detected antenatally or ante-mortem. You can do direct observation. I did a project in 2004 where I stood at bedsides and I videotaped people inserting central lines into babies. And when you analyze the videos, you find a lot of deficiencies in sterile precautions, technique, bleeding control, and just efficiency of how smoothly the procedure is done. So video and direct observation is very good for studying technical procedures and also teamwork during resuscitation or during rounds. You can also do surveys of administrative or billing data. And there's a methodology called PSI, Patient Safety Indicators, that the AHRQ uses. You can do chart review, you can do medical malpractice claims, and the IHI has promoted what's called a trigger tool, where you identify certain triggers. For example, if an antidote was used, you figure out how often the antidote was used and drill down to see if there was a medication error underlying the need for the antidote. For example, you can look at how often naloxone was used in your hospital in the last 1 year. And if you find 34 instances of naloxone use, you can review those charts to see if any of them had a fentanyl or a morphine overdose. So that's called a trigger tool. So there are many methods by which you can identify medical errors. So the main point I'm making here is be more aware of the possibility of medical error and use methods to track how frequently these are occurring in your unit. I don't know how many of you are doing this, but if you're not, definitely you should do it. And if you are doing it, you should try to enhance it and make it more rigorous. So what happens when an error or an adverse event is detected? You have to analyze why it happened. In the past, it was common to blame people and say, bad doctor, incompetent nurse, or sloppy respiratory therapist, and used to blame people and used to punish them or terminate them. But then the same error would occur in 6 months or after 9 months because you didn't fix the fundamental problem. So the Institute of Medicine report, building off of a long body of a huge body of science in safety in other industries, emphasized that you have to take a systems approach to promoting patient safety and preventing errors. So you shouldn't blame individuals. Look at the system and how the system contributed to the individual making an error. So this is one approach that I wrote about in a book chapter called the WHO method of analyzing systems. Instead of saying who is responsible, say who is responsible. Who as an acronym. Who stands for work conditions, human conditions, and organizational conditions. So when you analyze an event, you can find out that the work conditions were not favorable for our human functioning. For example, the schedule might be promoting fatigue, the equipment might not be working well, or the design of the workplace might lead to a lot of distractions and interruptions. There's no decision support. It's not easy to look up the dose of a medication if you're prescribing a medication. So you have to look at what the work conditions were. Human conditions are training, fatigue management, stress management, how well the team communicated. All these can contribute to the occurrence of medical errors. Organizational conditions are the safety culture, team training, leadership, allocation of resources to safety, how much effort and FTEs and resources are people allocating to patient safety. All these matter. And if there are deficiencies in any of these elements, it can cause the human being who's on the front end of the system, the sharp end of the system, to commit an error. So don't blame individuals, focus on systems. That's the important point. James Reason, who is a well-known expert on patient safety, created this Swiss cheese diagram. Every time you analyze an event, you find that the system already had layers of defenses intended to prevent an error from reaching the patient. Each layer of defense is imperfect and has holes in it, like layers of Swiss cheese. Normally, one layer of Swiss cheese that is intact covers up the hole in the preceding layer. For example, if I wrote a wrong dose of a medication on a patient, the pharmacist will check it and call me back and say, "Doctor, you wrote the wrong dose." But once in a way, the pharmacist might be busy and distracted, and he might let the error propagate. And the next layer is the nurse. The nurse should look at the order and say, "This is too high a dose of caffeine for a preemie. There's something wrong here." She should call the pharmacist or call the doctor, but she may be busy. So in that way, if all the holes in the layers of Swiss cheese line up, the error will reach the patient. And in every analysis that I've participated in with safety events, the Swiss cheese model always held up. That we had multiple mechanisms and they all failed at the same time. So this is what happens. Ideally, you want the layer of the Swiss cheese to trap the error, but sometimes it goes through and reaches the patient. Then after an error or adverse event has occurred, especially if the patient is harmed, you have to do a debriefing of the event. And you have to make it routine after all significant events. For example, if you go to a neonatal resuscitation and you had to do a prolonged resuscitation, intubation, chest compressions, lines, medications, definitely do a debriefing. Make debriefing a habit. The debriefers who conduct the debriefings have to be trained. You just can't go and say, "Okay, what went wrong? Tell me." They have to be very, very skilled in managing the psychology of the team. They have to be non-judgmental. They have to be non-critical. They have to be excellent listeners. And debriefing can be divided into hot debriefing, which is done immediately after the event, warm debriefing, which can be done like 1 or 2 days after the event, or cold debriefing, which can be done about a month or a couple of weeks after the event. By then, the emotions of the team have settled down, especially if something bad has happened. So you have to judge what's the best time. The longer you delay it, the less accurate the recall will be. The sooner you do it, the more intense the emotions might be, especially if things didn't go well. So you have to use some judgment with that. Or you might want to do it in multiple stages. So one good way to do debriefing is to ask 3 open-ended questions. What went well? What could have gone better? And what should we do differently next time around? I find these 3 questions a very good framework to use during debriefing. And there is actually a nice article by Rudolph and colleagues on how to do debriefings. I strongly suggest that you read that article by Rudolph. And then in the debriefing, what you need to bring out is what were the things that went well and that did not go well in multiple domains, cognitive. Did people remember the right things to do? Did they make the right assessment and analysis? Did they make the right decisions? Technical, did something go wrong during intubation or line placement or a chest tube placement? Then behavioral, how did the team communicate? Were people able to speak up? How did the leader of the team manage the team? And emotional, how were the emotions of the team managed during the whole incident? All these things have to be paid attention to. If you focus just on the technical side, you might miss some other important things that were contributing to the event. And then a disclosure has to be done transparently and openly after any adverse event. So if a patient is harmed, disclosure has to be done very, very transparently. That is the expectation in the US. And you should not try to sweep it under the rug or try to hide it. I don't know what the rules are in UAE, but we can talk about it during the discussion. You have to judge when to do the disclosure. And when you do the disclosure, you have to avoid speculation and you have to avoid over-disclosing things. Only tell the family or the patients what is known for sure and tell them that we are investigating, we're doing an analysis. We will tell you what the update is as we find out ourselves. Apologizing is an important part of any disclosure after a medical error or adverse event. And Aaron Lazar, who's a psychiatrist, has spent his career studying apologies in medicine, in politics, in history, in literature. And he says that true apology has 4 components. An acknowledgement that something was not done right, an explanation of why things went wrong, an expression of remorse that you feel bad that something didn't go right, and fourth thing, which we doctors should not offer, offer of compensation and say, making things right. We should involve our legal people and our administrators for the last thing. But remember this, those are the four components of apology. Acknowledgement that something went wrong, an explanation of why it went wrong, expression of remorse. You have to express that you feel sorry, because patients and families always feel angry that the doctor came in and he said that there was an error, but it looks like he didn't care. He looked very indifferent or almost defensive. So you have to express remorse that you feel bad that this happened. Families, in my experience, are very forgiving, and if you're honest with them and transparent with them, they will work with you. And there are some hospitals in the US which have adopted a conscious policy of disclosing errors very proactively and transparently. And if they say, if we investigate and we find that we made a mistake, we will be the first to come and tell you that we made a mistake, and we will offer to settle. And that has actually reduced the time to settlement and the total amount of settlement that is given to families. This was in the VA system, but in general, this is the approach we take in the US right now. And the other thing that families are often consoled by is if you promise that you will put in place mechanisms so that no other child is hurt the way that their child was hurt. They want that. They want that future children should be protected from similar errors. That's a very important part of disclosure. And again, during the Q&A, we can talk about this and I can share some personal anecdotes about this. I actually have a YouTube video, which was through an educational program from Harvard. You can look it up on this YouTube link, and it goes into a lot more details about how to do a disclosure. Okay, so that was some of the elements of a safety program. Have a reliable method to detect events, have a good method to analyze events, then what you do after an event, debriefing for the team, disclosure to the family. But then you have to put in place some safety solutions so that the system becomes safer and future patients don't get harmed. There are some generic safety solutions which apply to all types of errors, whether it's medication error, procedural errors, communication errors, or diagnostic errors. So those are leadership, teamwork, communication, safety culture, simulation, and involving family members in safety solutions. All these things can be done generically, no matter what kind of problem you're talking about. And then there are some specific solutions. For example, with medication, computerized physician order entry is widespread in the US, and we only order medications on the computer. And then before that, we used to have prescription rules, like the rule of 6 was removed. And how, like, don't put a 0 after a decimal point, always put a 0 prior to the decimal point. These are some prescription rules if you're still handwriting prescriptions. For invasive procedures, doing a timeout, and for surgery, doing timeout and doing checklists before you do the procedure. For patient identification, always using 2 identifiers, using the name bands and labels. For infection, you all know the precautions to take with IV catheters, hand hygiene, and prevention of multi-drug-resistant organisms. And for wrong route administration, for example, we've had incidents where milk was infused intravenously into babies. There are devices now where the NG tube will not fit into a IV catheter. So using mechanical constraints like that is a way to prevent wrong route administration. So for each type of errors, you have generic errors, and then you have specific errors. So this is the global picture of what I just talked about. So there is a sharp end where the nurse or the doctor taking care of the patient is involved in the error. But if you do an analysis, you will find that in the blunt end, there are error facilitating conditions in the system that cause the human being to be involved in the error. There are defenses that failed, and that leads to an error, and that leads to an adverse event if quick action is not taken to prevent damage to the patient. And systems analysis will tell you where things broke down. And after the event, you do disclosure, always involve risk management, and then care of the provider. The nurse or the doctor involved in the error is often very traumatized. That's known as the second victim. And you have to take care of their emotions because physicians, nurses, respiratory therapists who are involved in an error can suffer from severe PTSD, depression, anxiety. Many of them end up quitting the profession. And you have to provide them with psychological support and reassure them that they can still function. And there are many instances where nurses and physicians involved in errors have committed suicide after the event, especially if the patient died. Now I want to switch a little bit and I want your participation. What would you say to these questions? In your unit, it is easy to speak up about what is on my mind. People are usually comfortable talking about problems and disagreements. People are eager to share information about what does not work, as well as to share information about what does work. How many of them how many of you would answer yes to these questions? 1, 2, 3, 4. Excellent. A lot of people. I don't know how to survey the people online, but I'm hoping that a higher proportion of people listening online also would answer yes to these questions. Okay. What about these? In my unit, if you make a mistake, it is often held against you. And keeping your cards close to your chest is the best way to get ahead. What would you say to these questions? Still no? Some extent yes and some extent no. What did you say, sir? But does it happen in your unit? Okay. Okay. Any other comments on this? So the concepts that those questions are addressing is called psychological safety. And the world's expert on psychological safety is a Harvard Business School professor called Amy Edmondson. She has studied psychological safety not just in healthcare, but in all industries. And she has written a book on it called The Fearless Organization. Psychological safety is the belief that the workplace is safe for interpersonal risk-taking, and there is no formal or informal harm from speaking up, admitting mistakes or ignorance, asking for help, asking questions, and raising concerns. If you can create an organization and a workplace where people feel safe speaking up, and they say, I made a mistake, I'm sorry, and they're not scared that they'll lose their job. Or if they say, I have a question, I don't understand this, and they're not afraid that you'll think they're dumb, then you'll have the ideal safety culture. And this is what, as the chair of pediatrics, I try to promote in my department, that when somebody speaks up, first thing I say is, thank you for speaking up. I may not agree with you, I may not do what you asked me to do, but I will definitely thank you for speaking up. And I don't want you to feel afraid to speak up. Challenge me, even if I'm the chair. I will listen and I'll try to answer. So that's what leaders should do to promote psychological safety. And I strongly recommend that all of you read this book, The Fearless Organization, and she has a lot of YouTube videos as well. So you want to be in voice and not in silence. Should we take questions now or should we do it at the end? We'll do it at the end, Monica. Psychological safety is created by leaders who avoid using fear as a motivator, invite participation, use humble inquiry, which means they listen, they ask good questions, they respond productively to questions, and they destigmatize failure. So if somebody fails or makes a mistake, you don't hold it against them and say, it's a learning opportunity. I won't blame you, I won't punish you, but let's learn from this so that we get better every time. So that's what good leaders do. They promote psychological safety. And a unit or an organization can exist in one of 4 quadrants, where on the one hand, psychological safety can be high or low. On the other hand, standards can be low or high. If you have high standards and high psychological safety, that means you expect the best quality care for your patients, and you have high psychological safety, then your team is learning and they're performing at very high levels because they feel safe, they're thriving, they're energized, right? If you have high standards and low psychological safety, where people are afraid and they're on edge, then you're just generating anxiety. Yes, there will be some leaders who say, no, we have to be perfect, and they'll scare you. So you're always anxious when you go to work. If you have low standards and you have high psychological safety, everybody's comfortable because you can speak up and say anything. Nobody expects you to do anything good, and you just tolerate poor quality. So you're very comfortable. If you have low standards and low psychological safety, you're just existing in apathy. Nothing, nobody's trying to do anything, and it's just a very indifferent way to be. So you want to be in this quadrant where there's high standards and high psychological safety. That's what leaders should aim for in the real. So that was a little segment of psychological safety, which is one of the most fundamental underpinning concepts in patient safety. Now, I want to switch gears, and I want you to look at this X-ray and tell me what you see. Anybody? Yes, sir.
So pneumothorax and the chest tube has been put on the right side, but it is twisted, and I don't think it's breathing.
Okay. Right-sided chest tube, twisted and not draining. Okay. Anything else?
There's a little on the left side also.
Left side also tube, yeah.
And maybe it's not in this because it's in the lung or not in the lung.
Yeah, the left side chest tube could be in the lung. What else? So this was one of my patients. Okay, that's a subclavian catheter. Yeah. Okay, anything else? This was my patient, and this was the patient after a few days. This patient was very sick, preemie with pneumothorax, bad lung disease, eventually got better. And after he got better, the radiologist pointed out that if you look at the left humerus, it is a fracture. How come you didn't see that earlier? Now you're telling me after I tell you, right? So that is called a diagnostic error. I took care of this patient. We took care of the pneumothorax. We took care of the respiratory failure. Okay, so blame the radiologist. Blame the X-ray technician. You forgot the ABC. Tell us what the ABC is.
First of all, identify what is the patient, by the name, number, left side, right side, what view it is, PA. Then, after it is rotated or not rotated, then you should first A, B, C.
Yes. How come you didn't do that? So this is called a diagnostic error. I didn't do that either, because our human tendency is to look at an X-ray and immediately pattern recognition. Whatever jumps out at us, you say, okay, I see it. And then you say case closed. I've seen everything. Right. Yes. That's a line from Das's surgical clinical methods. Yeah. The eyes cannot see what the mind doesn't know.
Normal delivery, but he had a fractured humerus. It was not detected till 3 days.
Yeah. So after
there was even a video showing the mother or the nurse is giving bath to a child, and child is not moving the limb at all. It was still ignored for the 3rd day.
Right.
Of course, fractures are very easy. I mean, it doesn't cause any harm. I mean, it heals very well. Orthopedic doesn't do any very significant. And but the mother is telling, how did you miss this?
Yes, so let's talk about how these were missed. These are called diagnostic errors. Did you have a comment? Okay, so anybody in the audience who makes a comment, please use the microphone for the audience online. So let's move on. So the point is, This was a diagnostic error that I was involved in. And obviously, every one of you has been involved in an error of this kind. It might not be a fracture, but it might be something else. Yes, sir.
Brief attempt to pull out the subclavian line a little bit up because this might cause arrhythmias or something.
Yeah, that's a different issue. Yeah, but the main point here is I missed the fracture. Okay, that's called a diagnostic error. Why is this important? Because in 1999, the Institute of Medicine said patient safety is a problem, medical errors are killing thousands of patients. They didn't highlight diagnostic errors. Okay. Diagnostic error is the failure to establish an accurate and timely explanation of the patient's health problem and communicate that explanation to the patient. Okay. In recent years, it's been widely recognized that diagnostic errors are the most common type of medical errors. And they far outnumber medication errors, procedural errors, communication errors, teamwork errors, and so on. And this is an area that I've been doing some research on recently. And again, it's estimated that 40,000 to 80,000 people die every year in the US from misdiagnosis. This is patients of all age groups, not just pediatrics. In 5% of autopsies, there are lethal but preventable diagnostic errors. Tort claims, legal claims for diagnostic errors are twice as common as for anything else. And in 2015, the same Institute of Medicine released a report called Improving Diagnosis in Healthcare to highlight the importance of how we need to improve diagnostic safety. There is a society called SIDM, called Society to Improve Diagnosis in Medicine. And I go to the conferences every year if I can. And they're focused exclusively on improving diagnosis and preventing diagnostic errors. This is an article in JAMA, and what this says is diagnostic safety and preventing diagnostic errors is just a component of what's known as diagnostic excellence, because you have to be good at diagnosis in all aspects. You have to be parsimonious in the tests you order. You have to have good cognitive reasoning about why you're ordering certain tests and why you're making certain differential diagnosis. And you have to prevent diagnostic errors. So these are some data from publications in pediatrics. 21% of patients discussed in MNM have diagnostic errors. 20% of autopsies in PICU and NICU have diagnostic errors. 60% of malpractice claims paid have diagnostic errors. 12% of PICU patients suffer from diagnostic errors. And in neonates, it's the most common type of complaint or malpractice claim for the claims against claims about diagnostic errors. We did a study in 2022 where Grant Schaefer, who was my fellow at that time, he's a neonatologist in California now. We reviewed 600 consecutive inborn patients in the first 7 days of life. We developed a 12-question algorithm called the SAFER DX NICU instrument. And the diagnostic error was detected in 6.2% of study patients with a rate of 0.9 per 100 patient days. And we had multiple reviewers review the same charts, and there was substantial agreement. So it was not just one person arbitrarily making a decision. In 3 patients, that is 8% of identified errors, the diagnostic error potentially contributed to the patient's death. So why do diagnostic errors occur? How can we prevent them? Let's talk a little bit about that. This is the pathway that we were all taught in medical school. When you approach a patient, you take a history, do a physical exam, you generate a differential diagnosis, then you order some lab tests or imaging tests or consults, you make a diagnosis, then you revise your diagnosis. This is how it's supposed to occur. Unfortunately, I think everybody takes shortcuts. We get a history and immediately jump to investigation. So I can't tell you the number of times my resident or fellow will say, this patient had seizures, so I ordered an MRI and a neurology consult. And I say, wait, what was the differential diagnosis? What was the findings? Tell me about that. And they don't tell me. And even I take shortcuts sometimes. Like somebody will call me and I say, okay, order a CBC and a blood culture. And I'm coming in. I don't ask them what's the baby's activity level, what's the vital signs. So all of us have become kind of casual about history, physical exam, and differential diagnosis. Differential diagnosis is the one that is most often overlooked. And I think we need to go back to basics and just go back to good clinical medicine. Yazdani and colleagues published this beautiful paper in 2020 called the cognitive zipper problem. Because to understand diagnostic errors and to prevent them, you need to understand how doctors think or don't think, or they make mistakes in thinking. What they say is, as the patient comes to you, there is a representation of the problem that evolves with time and as you gather more information. At the same time, your cognition kicks in, and as the patient's information comes in, your brain starts analyzing and interpreting it. So it's what in your cognition as a physician and what the patient's problem representation evolves into. They come together just like a zipper, and ultimately that leads to a diagnosis. So both these things have to come together. The information has to be good and comprehensive and staged, and your thinking and cognition and knowledge have to come together with the information. So then you'll make accurate diagnosis. Poor history taking is common, and I mentioned that inadequate physical exam is very, very common now. In fact, one doctor calls it hyposcilia. It's widespread in medicine. So we do indiscriminate testing, over-reliance on test results. In the medical record or in handoffs, missing information is very, very common. And in the COVID-19 era, a lot of patients were being seen on telemedicine. So God knows what kind of diagnostic errors occurred in that era with limited information. So what do you see on this slide? This was the CSF findings of one of the babies that I was cross-covering one weekend in a NICU where I worked at. Does this patient have meningitis? So I was covering for the weekend, and the team that was on during the week had diagnosed this patient as having meningitis. They'd started broad spectrum antibiotics and put in a central line because they thought the patient had 156 cells per cubic millimeter. Preterm baby, 28 weeks. Okay, so 156 cells per cubic millimeter, therefore meningitis. PIC line, antibiotics. I was covering Saturday, Sunday. The resident says, Dr. Gautam, I don't think this patient has meningitis. I said, what do you mean? We looked down, and actually, the CSF showed 8 nucleated cells per cubic millimeter. That was the accurate cell count. And the lab had reported that they had counted 156 cells to generate the differential count. And the treating team had looked at the 156 and diagnosed meningitis. It doesn't matter. The point here is that the team had looked at the wrong cell and diagnosed meningitis. And I had to go tell the family, we're very sorry. The child does not have meningitis. We unnecessarily put in a PIC line, unnecessarily started antibiotics, and we have to take out the PIC line. And can you imagine how upset they were? And I was cross-covering on the weekend. So this is an example of how the system facilitates misdiagnosis, right? Because why would anybody report the number of cells counted for a different differential count, right? It's just creating confusion. In this hospital, it was. That's the. Yeah, but you might be at risk for some other type of error. The point here is the computer system made it easy for the doctors to make a wrong diagnosis. That's the point. Okay, I want you to tell me what do these patients have. An adult patient comes to you and says, I hear my eyes move. What does the patient have? No, he's hearing his eyes move. What? So what's the diagnosis? Now, how can misdiagnosis lead to audible sounds? So most people will think this patient is crazy. He's got a psychiatric illness. If I move my eyes, how can I hear, right? What's the diagnosis? So there is a diagnosis called superior canal dehiscence syndrome. Okay. And if you have that, if I move my eyes to the left and right, I can hear sounds in my ear. I didn't know this diagnosis existed. Okay. So if a patient comes to you and says, I hear my eyes move, you think, okay, refer to a psychiatrist. Because I don't have the knowledge to make the diagnosis, right? The point here is, one is the information systems can be faulty, but your knowledge may also be faulty. You might not know that this kind of diagnosis exists. I had a patient once, newborn with perinatal depression and encephalopathy. We did the cooling. The patient was acidotic, and after the cooling, did not wake up. The acidosis kept getting worse and worse and worse. We were all scratching our head. What do you think the patient had? So what's the diagnosis? So that patient had something called Barth syndrome. I had never heard of it. Barth, B-A-R-T-H. So when you said, what is that? That means you don't know about it. Yeah. So that's what I'm saying. The point of this slide is that there are some diagnoses we may not know about. So one problem is how the information is collected through history, physical exam, and lab tests, and how the information is presented to you. That might cause you to make a wrong diagnosis. The other problem is you might not know about those diagnoses. So that could also lead you to miss a diagnosis. But the most common problem that leads to a missed or wrong diagnosis is thinking, or faulty thinking. So I'll show you some slides and you tell me what these patients have. I want you to immediately respond, okay? Don't wait, don't think. Okay. How long does it take? Did it take for him to? Who said that? Kalyan, okay. Immediately he said that, right? Is he accurate? He just looked at it and he said, subcutaneous fibrosis. What does this child have? Yeah, again, within half a second, you made the diagnosis. What does this patient have? Say that again. Hypothyroidism. If I show this slide in the US, nobody will recognize it because they all do universal screening. They've never seen a clinically hypothyroid baby. Okay? Now, what does this patient have? A diagnosis. Don't even bother because this patient has something called Okamoto syndrome. There are only 37 cases reported in the world. You can stare at this image all day long and you'll never make a diagnosis. So what's the difference between making a diagnosis here and here and here? What happened here? Yes, so there was a famous psychologist called Daniel Kahneman. He just died last week at the age of 90. He is the foremost scientist on cognitive processes of the human mind, how we make judgments, how we make decisions, how we make analyses. He said that there are two types of cognitive mechanisms that human beings use. He wrote a book called Thinking Fast and Slow. And the title just summarizes it. There are some types of thinking that are very quick. That is called system one. It's intuitive. You say, okay, that's subcutaneous fibrosis. That's Down syndrome. Then there are system two, which is slow and analytic. You slow down, you say, okay, the eyes are widespread. He's got a squint, and he's got a slight, lowering of the ears. You slow down and you do systematic analysis. Which system is better? Which system is better? You need both. Because if you're in a clinic and you're seeing patients every 15 minutes, you can't slow down and say, okay, tell me about your family history, your grandfather's occupation, physical exam. And then you write down and you slowly do the analysis. This patient has diarrhea, but could it be lactose intolerant? You'll never get through a clinic. So you have to be quick. Or in an emergency, you can't say, okay, this patient is hypoxic, turning blue. and his limbs are twitching. So my differential diagnosis, you have to say, no, get the oxygen, put in an IV, blah, 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 right? So you need both. You need to know when to use system one, when to use system two. If you always use system one, then you'll make mistakes because you're in pattern recognition, quick judgments, and you'll miss the subtle things like the fracture. That's what happened to us, right? And to me, I was using system one. I said, okay, pneumothorax, chest tube, subclavian. I missed the fracture. When you say ABC, that is system two, right? You have to be methodical in how you approach. So system two is slow and systematic, but it takes a lot of time. System one is quick, but it can mislead. Investing in stocks, system one or system two? System two is better, right? So in system one, human beings often use heuristics, okay, which are shortcuts in reasoning, which are subconscious rules of thumb used to solve diagnostic puzzles. For example, if I say, should I invest in stocks? And I say, Sridhar, are you investing in stocks? And he says, yeah, I just bought 100 stocks of this company. I say, okay, I'll also buy it. That's a heuristic. Sridhar is smart. He bought stocks, so I'll do the same thing. That's a heuristic. I'm not using analysis. Okay, I'm not using the fundamentals of the stock market. So heuristics and biases are efficient mental strategies with which to deal with an uncertain and ambiguous world. We use it all the time. They work on many occasions, but they occasionally fail. They're not intrinsically good or bad, but that's just how we humans function. So Malcolm Gladwell wrote a book called Blink, where he extols the virtue of quick decision-making and heuristics. And in contrast, Michael Legault wrote a book called Think, which emphasizes that you should not always be in a quick judgment pattern and jump into conclusions. You should think sometimes and use some cognitive reasoning, have some skepticism. So you need both system one and system two. What do you read? Read these sentences out aloud, please. Okay, now read them slowly and see what the mistake is. Yeah, how come you didn't spot that when you read it? How come you didn't spot it when you read it? You didn't say Paris in the spring, right? So that means when we're reading also, we just pattern recognize, right? And whatever makes sense, our brains latch on to. That's an example of system one. So if you're in system one and you're in this heuristic method, there are a lot of cognitive processes that lead to error, like availability heuristic. So if I just saw a patient with Barth syndrome, the next patient with HIE, to me, I'll say, oh, could this be Barth syndrome? Right? That happened to me. I had that patient, and the next 20 patients, I'm thinking, oh, maybe this is Barth. That's called availability heuristic. Confirmation bias is at the history stage, you make a diagnosis, and everything else from that point on, you say, yeah, this is neurofibromatosis. I'm going to look for cafe au lait, family history, and you ignore that it could be something else. Premature closure is a tendency to stop too soon and not order the critical test or gather the critical. That's what happened to us with the pneumothorax. So the pneumothoraces, the chest tubes, we said, okay, we made the diagnosis, case closed. That's called premature closure. We didn't look at the bones. Then base rate neglect, tendency to ignore the true rate of disease and pursue rare but more exotic diagnosis. Like if somebody comes in with some hepatosplenomegaly in the US and you say, okay, this could be Chagas disease, you're ignoring the base rate that in Wisconsin, don't really see Chagas disease. But if you're in South America, it's a different. So you need to use some judgment about the base rate. Representativeness is a tendency to be guided with the prototypical features of disease and miss atypical variants. Framing effect is being swayed by how information is presented or framed. Like when a referring doctor calls you and says, I'm sending a patient with meningitis to you. You'll say, okay, there's a patient with meningitis. So instead of that, you should say, okay, he's saying it's meningitis, but I'm not going to assume it is. It could be something else. I'm going to start fresh. So don't be influenced by the framing effect. The other thing that doctors consistently suffer from is overconfidence. They've done studies where they give case vignettes of cases to doctors and asked them to make a diagnosis and asked them to rate their confidence in how accurate their diagnosis is. There was no correlation between accuracy of diagnosis and degree of confidence. So even the most inaccurate diagnosis, the doctors were highly confident that they were right. So just because you think you're right doesn't mean you're right. In fact, you could be way off base and still feel very confident that you're making the right diagnosis. So that's another way our brain misleads us. So the point here is diagnostic errors are common, and flaws in thinking underlie a lot of the diagnostic errors, as do problems with information and lack of knowledge. How do you prevent diagnostic errors? There are many methods described. None of them have been studied well, and the evidence for these is very, very low quality. You can have diagnostic checklists. You can do metacognitive training and reflective practice. You can do a diagnostic timeout and pause to reflect and say, okay, this patient has come to me with this condition. I think this is the diagnosis, but could I be wrong? Could I be missing something? Should I think of something else? So you force yourself to do a timeout and say, let's think of what I could be missing. That's also known as a cognitive forcing strategy. And team members can offer that to other team members, saying, okay, Sridhar is saying this patient is this, but could it be something else? Could it be this alternative diagnosis? And you offer that. Prospective hindsight technique is a method where you make a diagnosis, then you assume that you're wrong. Okay, then pretend that you're doing a root cause analysis or M&M about the diagnosis that you missed. And then you say, I made a mistake and now I'm doing an analysis. So you prospectively, you're using hindsight. So that is a technique that has been recommended. Again, none of these are highly evidence-based. And of course, follow-up. You admit a patient and you go off service and you take time off. You don't know what happens to that patient. So always follow up what happened to that patient you admitted. Like when I went to PGI in February, they showed me a case and I thought this could be CMV. And I went back to the US and I kept messaging them on WhatsApp saying what happened to that patient. And indeed it was CMV. So I felt happy that we closed the loop. So follow-up is very, very important. There's actually a systematic review of 26 studies of strategies to reduce diagnostic errors. That includes methods such as communication methods, audit processes, additional patient reviews, checklists, and so on. But all of these had limited evidence of efficacy. So we really don't know how to prevent diagnostic errors. We need to do a lot more research in this field. These are my take-home points. If you want to have a perinatal safety program, have the 5-pronged approach where you have good methods of detecting errors, analyzing them, responding to errors, and put in safety precautions both at a system level and at individual level. Psychological safety is critical to patient safety. Diagnostic errors are common and serious, and cognitive biases underlie many such errors. Thank you for your attention. And should we do questions now? Or?
Actually, there are a couple of questions online. If anyone in the audience has a question, please write it or come here and say it. Or you can take it. Don't speak without the mic, please. Then we'll just take 5 minutes for the questions. We'll go for the panel discussion. The question online, one of them is there a role for artificial intelligence in improving this process? Have you looked into it?
Very good question. I think there will be, but I personally have not done any work on that, or I don't know of any evidence for that. But I think it's definitely a promising methodology.
It's about application of this, like culture of safety is not widely applied in the developing world as it is in the developed countries. And even in countries like UAE, I wouldn't say 100% as Dr. Mansoor said as well. It's not 100% applied, though you may try to do it in the best institution. So the question from them was how to improve it in the developing world, and secondly, should be part of medical education, which I think in the developed world it already is, but should it be incorporated everywhere?
I think so. The question is how to improve the culture of safety, especially in the developing world. It all boils down to leadership, and if leaders commit to promoting psychological safety and spreading it through their unit or their organization, I think you can really slowly start making inroads into that, and you can start with your own area of influence. If you're the medical director of your NICU, you can create psychological safety in your NICU. If you're the director of transport, you can create it there. So you can create little islands of psychological safety, and hopefully it will spread. But it's a real problem. Many people are afraid to speak up. They don't want to raise concerns, and they'll keep quiet rather than making waves.
I mean, when we talk about culture of safety and we are encouraging people to ask questions, the question is like, how many times in your experience, like, when it's questioned to the leaders or, and it has been taken positively and no, if you don't do like, you don't do anything at that point of time, but, indirectly or somewhere in your mind as a leader, you would treat or think something differently, because that's what I have seen, because as much as when, because we do have incident reporting system and things that people are encouraged to write, as long as it is for the others, it's okay. But when it comes to, the leaders and they are being questioned, I've seen a very hostile kind of thing directly or indirectly, and how to take care of that.
Absolutely. So my approach is that psychological safety is important, but you also have to be pragmatic. You can't just go around, criticizing everybody and pointing fingers at everybody. That will be fatal to your career. So my method has always been to try and push up to the limit of safety and try to do it in a diplomatic, gentle way. And say, how about if we consider this? Could that be a possibility here? So if we can raise concerns in a non-threatening way that doesn't throw your boss under the bus, you have a better chance of being heard. And certainly in the area where I am in charge, I try to encourage people to speak up freely without trying to massage the truth. And just say it like it is. And people will come to me and they'll try to be diplomatic and say, just tell me straight what you want to know, and I won't be angry. I may not agree with you. I may not do what you want me to do, but just say it. But when I speak up to my superiors, I have to judge very carefully how they will receive it. And sometimes you have to wait for the right opportunity. Sometimes you have to put it in a very diplomatic way, or you have to make them look good. So that's important. So psychological safety has to be balanced with organizational pragmatism. Let's say that.